Your last blood pressure reading was a number your physician discussed with you. The intervention that reduces that number more effectively than running, cycling, or any exercise ever studied across 270 randomized controlled trials is not an exercise. It requires no heart rate elevation, no cardiovascular endurance, no movement. 2 minutes. The field missed it for 40 years because the therapeutic event does not occur during the intervention, it occurs after. Hold is the preparation, release is the medicine. Data, first the numbers need to land before the mechanism can explain them. Edwards and colleagues at Canterbury Christ Church University gathered every randomized controlled trial measuring blood pressure response to a specific exercise modality, then used network meta-analysis, a statistical method allowing indirect comparisons between interventions never tested against each other in the same trial. A controlled tournament with blood pressure reduction as the only outcome. Isometric exercise, sustained muscular contraction without movement, the wall sit being the most studied protocol ranked first. Above aerobic exercise, above dynamic resistance training, above high-intensity interval training, above everything the clinical guidelines had been recommending for 4 decades. Effect size: 8 mm of mercury systolic reduction, 4 mm diastolic. The epidemiological literature on blood pressure tracking millions of adults across decades consistently finds that an 8 mm of mercury reduction in systolic blood pressure is associated with approximately 22% reduction in cardiovascular mortality risk, as Lewington and colleagues established in The Lancet across 61 prospective studies involving 1 million adults. A 22% reduction in the risk of dying from a cardiovascular event, from 2 minutes against a wall. Your physician has probably not mentioned the wall sit. For 40 years, the recommendation was aerobic exercise, running, cycling, swimming. The data now shows that a position requiring no movement outperformed all of them for this specific outcome. Why the field missed it for 40 years? Because the assumption that hid the mechanism was so intuitive it was nearly invisible. Exercise scientists measured what happens to blood pressure during exercise. Heart rate rises, cardiac output increases, peripheral vascular resistance adjusts. The system adapts over time. Plausible, supported, reflected in every guideline since the 1980s. And underneath the measurements sat a second assumption. The therapeutic effect happens during the exercise. Blood pressure does not drop during the wall sit. It may rise as the cardiovascular system works to maintain perfusion pressure through a partially occluded vascular bed. The effort is real, the quadriceps burn, the trembling arrives at 90 seconds, and the blood pressure is not falling. Wall sit's therapeutic effect is a post-exercise event. The reactive hyperemia cascade, the surge of blood through vessels that were compressed during the hold, arrives after you stand up. The hold creates the condition. The release delivers the outcome. The field was measuring what happened during the exercise. The wall sit's medicine happens after. You now know the data and the paradox it produced. The question changes from what happened in the tournament to what happens inside the blood vessels during the 60 to 90 seconds after you stand up. Vascular event next. This is the mechanism that running cannot replicate. During the wall sit, 4 muscles contract simultaneously: rectus femoris, vastus lateralis, vastus medialis, vastus intermedius. Together they form the quadriceps, the largest muscle group in the body. The isometric contraction produces intramuscular pressure that rises with each passing second, compressing the capillaries running through the muscle belly, partially occluding blood flow through the quadriceps. Like a thumb pressing on a garden hose. Blood flow through the muscle reduces. Metabolites accumulate and oxygen drops. The tissue downstream of the occlusion runs on limited supply. Moment you stand up, intramuscular pressure drops instantaneously. The capillary bed that had been partially compressed is suddenly open. The blood that had been building pressure behind the partial occlusion surges forward at velocity. This surge is reactive hyperemia, the body's compensatory flood of blood through vessels that were temporarily restricted. Surge does not just deliver oxygen to depleted tissue. It produces a specific mechanical event on the inner lining of every blood vessel it passes through, and that event is where the blood pressure reduction originates. Endothelial cascade next. The physics converts a mechanical force into a chemical signal that relaxes arterial walls throughout the body. Every blood vessel is lined with a single layer of cells, 1 cell thick, the endothelium, covering approximately 7,000 square meters when unfolded. The enos pathway, the sitting discussion, describes shear stress activating the enzyme L-arginine converting to nitric oxide, the gas-relaxing arterial smooth muscle, through a cyclic GMP cascade that self-perpetuates for 20 to 30 minutes after the nitric oxide itself has vanished. Operates here through a trigger continuous exercise cannot replicate. Reactive hyperemia sends blood surging through the previously occluded capillary bed, hitting the endothelial cells at a velocity that running's continuous, distributed flow never produces. The compressed then released pattern generates a peak shear stress event, concentrated, acute, intense, that activates enos more forcefully than the steady-state shear stress of continuous exercise. The endothelium does not experience this during a run because blood flow during running never stops and restarts. The wall sit creates the stop, the release creates the restart, and the restart is the peak. Smooth muscle relaxes. The arteries widen, not just in the legs, but throughout the entire peripheral arterial system. The vascular bed of the whole body responding to a signal generated in the endothelium of the thighs. Peripheral vascular resistance drops, systemic pressure falls, the settling you feel 60 to 90 seconds after standing, the slight drop in internal tension, the quiet that arrives without sleepiness is peripheral vascular resistance dropping systemically. Nitric oxide reaching the smooth muscle of arterial walls throughout the body. Blood pressure falling because the release after the hold produced a vascular surge that running's continuous flow does not replicate. Bilateral dimension amplifies the vascular effect beyond what any single leg exercise produces. The wall sit loads both quadriceps simultaneously and symmetrically. Both legs' capillary beds are partially occluded during the hold, and both decompress simultaneously on standing. The reactive hyperemia volume is doubled compared to a single leg contraction because two complete vascular beds are surging simultaneously through two complete sets of endothelial surfaces. Most daily activities, walking, climbing stairs, standing from a chair, load one leg at a time, producing unilateral vascular events. The wall sit produces a bilateral event that generates twice the shear stress surface area per hold. The bilateral symmetry also ensures equal quadriceps loading on both sides, preventing the strength asymmetry that accumulates from favoring one leg during daily activities and that contributes to gait instability after 60. The onset comparison to medication matters for anyone already on antihypertensives. A newly prescribed blood pressure medication takes 2 to 4 weeks to reach full therapeutic effect. The pharmacological pathway requires sustained receptor occupancy, vascular remodeling, and fluid volume adjustment before the numbers change. The wall sit produces a measurable blood pressure reduction within the first session, 60 to 90 seconds after the first hold. The acute reduction is present. The structural adaptation over 4 to 8 weeks parallels the medication's timeline, but the acute benefit begins on day 1. For anyone whose physician has just prescribed medication and who is waiting for the drug to reach full effect, the wall sit provides acute reduction during the pharmacological lag, a bridge that the prescription alone cannot provide during its onset period. Repeated blood pressure spikes during holds followed by post-release drops produce a second adaptation. The acute cascade alone does not explain baroreceptor resetting. Arterial baroreceptors in the carotid sinus and aortic arch are pressure sensors that regulate blood pressure by adjusting sympathetic and parasympathetic output. They are adaptive sensors that reset to whatever pressure they experience most frequently. Chronic hypertension resets them upward. The sensors accept 145 as normal and stop triggering the corrective response. Repeated wall sit cycles reset them in the opposite direction. The post-release troughs, occurring daily, teach the sensors that the lower pressure is the baseline the body should maintain. Baroreceptor resetting bridges the acute post-release reduction to the structural adaptation that emerges by week 4. The endothelial enos upregulation changes the vascular hardware. The baroreceptor resetting changes the control system that regulates the hardware. Both adapt through repeated exposure to the hold and release cycle. Sustained isometric load followed by release also shifts the autonomic nervous system from sympathetic dominance during the hold to parasympathetic rebound after the release. Repeated cycles train the vagal recovery reflex, the reflex that determines how quickly the heart rate settles after any cardiovascular demand. Heart rate variability, the beat-to-beat variation reflecting parasympathetic tone, improves measurably with regular isometric practice. For anyone whose resting autonomic balance has shifted towards sympathetic dominance with age, the wall sit provides autonomic retraining through a controlled, repeatable stimulus that the morning walk does not engage at equivalent intensity. Well, the quadriceps, because the muscle burning during the hold predicts something you have never been told about. Quadriceps, cross-sectional area, the size of the muscle at the front of the thigh, predicts 10-year survival in adults over 45 more strongly than blood pressure, resting heart rate, or VO those max, in multiple independent longitudinal cohort studies. Men in the lowest quartile of quadriceps strength carry a 30 to 40% higher risk of death within the next decade compared to men in the highest quartile. Mechanism runs through 3 simultaneous pathways. The quadriceps is the body's largest glucose sink. When it atrophies, the capacity to clear glucose from the bloodstream decreases and insulin resistance accelerates. The quadriceps is the structural anchor of gait mechanics and upright mobility. When it weakens, the pelvis shifts, the lumbar spine compensates, and the cascade from weakness to spinal degeneration to chronic pain to reduced mobility to further atrophy begins. And the quadriceps is the primary structure determining whether you can rise from a chair without assistance, catch yourself during a stumble, and generate the force needed to climb stairs, the functional capacities that determine independence after 70. Wall sit loads the muscle that predicts survival while simultaneously generating the vascular event that reduces the cardiovascular risk the survival prediction measures. 2 outcomes from one position, the muscle strengthening and the blood pressure dropping through mechanisms that have nothing to do with each other except that they share 2 minutes against one wall. That correlation, the muscle burning in the thighs predicting 10-year survival, more reliably than the blood pressure cuff on the arm, ended any calculation about whether 2 minutes against a wall was worth the discomfort. Femoral neck loading adds a dimension the quadriceps mortality data alone does not capture. The wall sit produces compressive force through the hip joint. The quadriceps pulling on the patella tendon transmits force through the femur into the femoral neck, the narrow bridge of bone connecting the femoral head to the shaft. Femoral neck fracture is the single most consequential fracture in the 65-plus demographic, associated with 20 to 30% one-year mortality, as Hyenchens and colleagues quantified in their meta-analysis in the Annals of Internal Medicine. Loss of independent living in over 50% of survivors, and a functional decline trajectory that frequently proves irreversible. The bone at the femoral neck maintains density in proportion to the mechanical loading it receives. Walking loads the femoral neck at 1 to 1.5 times body weight per step. The wall sit loads it continuously at body weight for 2 minutes, a sustained loading event that the bone reads as a stimulus to maintain density at the exact anatomical site where fracture carries the highest mortality. The isometric hold provides time under tension at the femoral neck that no number of walking steps replicates, because each step loads the bone transiently while the wall sit loads it without interruption. Isometric contraction depletes local muscle glycogen, opening the acute glucose disposal window that follows any sustained muscular demand. A meal within 2 hours of the wall sit produces a measurably lower glucose spike. For anyone managing blood glucose, pre-diabetic, insulin-resistant, or tracking post-meal numbers with a monitor, the wall sit before a meal provides glucose disposal enhancement alongside the vascular benefit. Blood pressure reduction through endothelial nitric oxide, glucose management through GLUT4 translocation, 2 outcomes operating in parallel from one position. You now know what the vascular cascade produces and what the muscle predicts. The question changes from what the wall sit does to the blood vessels and the quadriceps, to what else the sustained isometric load signals to systems far from the legs. And then growth hormone, because the burning in the quadriceps sends a signal the hypothalamus has been waiting for. Sustained isometric load on the quadriceps sends signals through group 3 and group 4 afferent nerve fibers to the hypothalamus. These are the pain-sensing and metabolite-sensing fibers that detect the lactate accumulation, the hydrogen ion buildup, and the oxygen depletion in the contracting muscle, the burning sensation that intensifies across the hold. The hypothalamus responds by releasing growth hormone, releasing hormone into the hypothalamic pituitary portal system. The anterior pituitary answers with growth hormone at 3 to 4 times resting levels within 20 to 30 minutes of the hold. Growth hormone declines approximately 14% per decade after 30. By 55, most adults are at roughly 50% of their peak output. Wall-sit sends the signal. The endocrine system was designed to receive a signal that sedentary modern life, with its chairs and lifts and escalators, has progressively eliminated. The burning in the thighs is the afferent message. The growth hormone release is the hypothalamic reply. The discomfort and the adaptation are connected by the nerve fibers that carry the signal from the muscle to the brain. Nasal breathing adds a dimension. The wall-sit generates nitric oxide from two separate sources simultaneously. Sinus-derived nitric oxide, the breathing discussion described, adds a second source during the hold separate from the endothelial enos pathway the reactive hyperemia activates. During the wall-sit, nasal breathing generates sinus-derived nitric oxide with each inhalation and exhalation. The inhaled NO reaches the pulmonary vasculature and improves ventilation perfusion, directing blood flow to the best ventilated regions of the lungs. Simultaneously, the reactive hyperemia after standing activates endothelial enos and produces systemic arterial NO, two independent sources of one molecule, operating through different anatomical pathways, activated by a single 2-minute intervention. The nasal breathing produces pulmonary NO continuously during the hold. The reactive hyperemia produces systemic NO after the hold. The combined delivery exceeds what either source provides alone. Breathing protocol during the hold: inhale for 4 seconds through the nose, exhale for 4 seconds through the nose. No breath holding at any point. Holding the breath during isometric contraction triggers the Valsalva response, which spikes intrathoracic pressure, reduces venous return, and can produce dangerous blood pressure elevation in anyone with cardiovascular risk factors. The controlled nasal breathing maintains venous return, produces sinus NO, and prevents the Valsalva spike that breath holding produces. Stand slowly, then stand still. This is when the endothelium activates, when nitric oxide diffuses into the arterial smooth muscle, when blood pressure drops. Collapsing into a chair immediately after the hold compresses the vascular bed that was about to receive the reactive hyperemia surge. Sitting down immediately misses the cascade that the hold was creating the conditions for. Stand for 60 to 90 seconds. Let the vascular physics run. Why every mechanism described above matters more after 45? Because 4 age-related declines converge on the same 2-minute position. Quadriceps mass declines 8 to 12% per decade after 40 in the absence of adequate loading. By 60, a sedentary adult may have lost 20 to 24% of peak quadriceps mass, 1% per year, quiet, incremental, invisible, until the chair becomes difficult and the stairs become avoided. Endothelial function declines with age. Enos activity decreases, nitric oxide bioavailability drops, arterial stiffness increases. The reactive hyperemia response the wall-sit triggers becomes proportionally more important as the baseline endothelial function it supplements is declining. Blood pressure rises with age. Arterial stiffness, reduced baroreceptor sensitivity, and increased sympathetic tone all contribute to the progressive hypertension that affects the majority of adults over 55. The 8 mm systolic reduction is proportionally more meaningful when the baseline is 140, bringing it to 132, potentially below the treatment threshold, than when the baseline is 118. Growth hormone output is halved by 55. The hypothalamic signal the wall-sit provides through the afferent nerve fibers detecting the metabolite accumulation in the quadriceps sends the activation that sedentary life has progressively withdrawn. The wall-sit becomes more valuable with every year because every system it addresses is declining faster. That cascade, a vascular surge the field missed for 40 years, an endothelial enzyme producing a gas with a 3-second half-life that triggers 30 minutes of smooth muscle relaxation, a muscle whose size predicts whether you are alive in 10 years, and a growth hormone signal the hypothalamus has been waiting to receive, is why the settling after the wall-sit carries more cardiovascular physics per second than any movement the 270 trials measured. Find any wall. Back flat against it, every vertebra that can make contact making contact, natural lumbar curve maintained. Slide down until the thighs are parallel to the floor, knees at 90 degrees directly above the ankles, feet flat and hip width apart. 90-degree specification is the angle that maximizes the vascular physics the cascade depends on. At 90 degrees, the force vector through the patellar tendon produces the highest compressive load on the quadriceps muscle belly, maximum intramuscular pressure, maximum capillary occlusion, maximum reactive hyperemia after release. Shallower angles 120 degrees. The easy wall sit reduce intramuscular pressure and therefore reduce the capillary occlusion that drives the entire cascade. Deeper angles shift load from the muscle belly to the patellar tendon and joint capsule, producing knee joint stress without proportional vascular benefit. The angle is not arbitrary, it is the mechanical position that produces the largest pinch on the hose. Isometric loading at this angle also produces a specific adaptation in the patellar tendon that dynamic exercise does not replicate as effectively. Sustained load at a fixed muscle length stimulates collagen synthesis and cross-linking in the tendon, increasing stiffness and load tolerance. For anyone with patellar tendinopathy common after 55, often misattributed to bad knees, isometric loading at the wall sit angle is a first-line rehabilitation protocol, specifically because the sustained load triggers the tendon remodeling response that repetitive, dynamic loading can aggravate. The wall sit simultaneously treats the tendon and trains the muscle, two adaptations from one position that many people avoid because they assume their knees cannot tolerate what is actually the prescribed intervention for the condition they fear. Breathe through the nose 4 seconds in, 4 seconds out. No breath holding at any point. The Valsalva response described above is the risk the controlled nasal breathing prevents. When the trembling begins at 90 seconds, stay. The trembling is the nervous system cycling through its motor unit reserves, exhausting one pool of fibers and recruiting the next. When the urge to stand becomes urgent, stay. The urge is a nerve signal from group 3 and group 4 afferents detecting metabolite accumulation, the signal the hypothalamus is reading. The discomfort is the message. The growth hormone is the reply. 2 minutes, then stand slowly and stand still for 60 to 90 seconds, the reactive hyperemia window described above. Sitting down immediately misses the cascade, stand and let the physics run. Protocol variation, the research supports most strongly, is 4 sets of 2 minutes with 1 to 2 minutes of rest between sets, 8 minutes of isometric loading per session. Each hold and release cycle produces a reactive hyperemia event, and 4 cycles in sequence produce 4 consecutive shear stress events that the endothelium receives as a repeated training stimulus. The cumulative enos activation from 4 cycles exceeds what a single hold provides. The endothelial adaptation signal scales with the number of hold-release cycles rather than with the total duration of a single hold. For anyone beginning at a fitness level where 2 minutes exceeds current capacity, common in the 60-plus demographic, 30 seconds is sufficient to initiate the reactive hyperemia cascade. Capillary occlusion begins within seconds of the isometric contraction. 4 sets of 30 seconds with 60-second rest intervals provides the repeated shear stress stimulus while remaining within a tolerable loading window. Build the hold duration by 15 seconds per week. The quadriceps adapt, the position stabilizes, and the enos response strengthens as the hold duration extends. Now the adaptation timeline, because what changes inside the vasculature across weeks of daily practice reveals the structural nature of the response. During the first week, the blood pressure reduction is acute, lasting 2 to 4 hours after each session, returning to baseline by the next day. The enos enzyme is being activated but has not yet increased in quantity. If you own a home blood pressure monitor, measure before the wall sit and 90 minutes after the acute reduction is visible in the numbers from day 1. During weeks 2 through 4, the acute reduction persists longer as NOS expression increases structurally. The endothelial cells are building more of the enzyme that converts the mechanical signal into the gas. The baroreceptors are resetting downward through the repeated post-release troughs. Check fasting morning blood pressure on practice days versus rest days. The gap between them narrows as the structural adaptation develops. By weeks 4 through 8, resting blood pressure declines measurably. The structural vascular adaptation is established. Enos levels remain elevated between sessions. Baroreceptors have accepted the lower baseline, and the arteries have undergone remodeling that increases their compliance. The 8 mm reduction Edwards documented was measured at this sustained adaptation phase. Morning blood pressure on rest days begins matching practice days. The adaptation has become independent of the acute session effect. Wall sit, is not the only isometric position that produces the cascade. Isometric hand grip, squeezing a hand dynamometer at 30% of maximum voluntary contraction for 2 minutes, produces the same vascular physics through the forearm musculature as Carlson and colleagues documented in the Mayo Clinic proceedings. The effect is genuine but smaller in magnitude because the muscle mass involved is smaller. The quadriceps generates more intramuscular pressure across a larger capillary bed, producing a larger hyperemia event and more intense endothelial shear stress. The wall sit outperforms the hand grip because the hose is bigger and the surge is greater. For anyone whose knees cannot tolerate the 90-degree position, the isometric hand grip provides an alternative that activates identical endothelial physics through different musculature. And then the medication interaction, because anyone taking blood pressure medication should understand the interaction. The wall sit reduces blood pressure through nitric oxide-mediated smooth muscle relaxation, a pathway that operates independently of most antihypertensive mechanisms. ACE inhibitors work upstream. Calcium channel blockers work at the smooth muscle through calcium pathways. Nitric oxide works through cyclic GMP, a separate route. The effects are additive, which means the wall sit can reduce blood pressure on top of the medication's reduction. If you are on antihypertensive medication and your blood pressure is already well controlled at the lower end of normal, the additive reduction could produce lightheadedness on standing. Start with shorter holds and monitor how you feel in the 60 seconds after standing. If symptoms occur, discuss the protocol with your physician. The medication dose may need adjusting as the vascular adaptation develops. Anyone with a history of aortic aneurysm, uncontrolled hypertension above 180 systolic, or recent stroke should not perform isometric holds without physician clearance. The transient blood pressure elevation during the hold can reach 160 to 180 systolic in individuals with baseline hypertension. For stable, controlled hypertension, this transient spike is within physiological tolerance and is followed by the therapeutic reduction. For uncontrolled or structurally compromised vasculature, the spike carries risk. The settling 60 seconds after the wall, the internal quieting, the drop in tension that is physical rather than emotional, the cardiovascular system operating at lower resistance through arteries whose smooth muscle relaxed because a gas with a 3-second half-life triggered a cascade that persists for 30 minutes, is the sensation I check. For every time the hold ends and the standing begins. Stillness ranked first across 270 trials. The position that moves nothing produces a post-release vascular event. That movement cannot replicate reactive hyperemia, surging through a capillary bed, the isometric hold compressed, hitting endothelial cells at velocity, activating eNOS within seconds, converting L-arginine to nitric oxide, the gas diffusing into smooth muscle walls throughout the body, peripheral resistance dropping, systemic pressure falling, 8 millimeters of mercury, 22% cardiovascular mortality reduction, 2 minutes, 1 wall. The blood pressure does not drop during the hold. It drops after. The medicine was always in the release.